Hi, everyone, and welcome to today's webinar, Structural Racism in Tech for Social Determinants of Health Solutions. My name is Artia Rogers, and I am the Director of Programs for the California team at HealthLeads, and I'll be moderating today's conversation. Now, for those who may not be familiar with HealthLeads is an innovation hub that runs both national and local initiatives that address the deep societal roots of racial inequity that impact our health. Here at HealthLeads, we believe that to address those deep societal roots of inequity, we have to have larger conversations like this one around structural racism. But before we enter this conversation today, I would like to spend some time centering us before diving in. Often discussions of structural racism raise antennas and sometimes create defensiveness. I want to lessen some potential tension that some may feel regarding this panel discussion, as this is not an attack on technology. Nonetheless, I think it is important for us to be honest about how structural racism exists, even in this well-intentioned field of social care, and even more so around our approach to social care. However, this panel is also not constructed in a manner that puts the onus on the panelists or the moderator to prove that structural racism exists in this field, because there's no debate if structural racism is in this field, because structural racism exists all around us. And with the recent rallies and push for social justice that yielded many anti-racism commitments from so many organizations, we have a responsibility to lean into this topic. If we're serious about our commitments to anti-racism and our desire to truly see people better off, we have to approach this conversation with humility. All of us have engaged in structurally racist systems, and we all run the risk of perpetuating those systems. So in this work, an anti-racism commitment requires us to check whether our well-intentioned efforts to address social or resource needs are truly benefiting and not creating harm for the communities and people we hope these efforts serve. This commitment requires us to interrogate our actions and make necessary changes. It causes us to place the most oppressed groups' needs in the center, not our own organizational priorities and needs. This anti-racism commitment should drive us to understand that systems, even those that are well-intentioned, can create harm and exploitation. And it's our responsibility to not only minimize risk of harm and exploitation with the hope of eliminating it, but to also respond with restorative justice when it has taken place. So if we're not up for this type of interrogation and we're not willing to make necessary changes, then we have to question if our well-intentioned efforts are just simply symbolic. For we will begin to just normalize structural racism in our own work. So I implore everyone today to take a moment in this discussion just to sit in the conversation. Feel the weight of some of the critiques from multiple perspectives and refrain from immediately seeking quick checklist solutions to problems that have multi-century roots. Because our call to action may center on collective reflection and action that requires revamping and/or dismantling of oppressive systems, meaning we may have to actually begin to pull out the roots. So with that, in our webinar today, panelists will discuss how tech-forward approaches promote and perpetuate structural racism and bias, the risk of normalizing structural racism and bias in tech-forward social care approaches, and steps that both limit and address harm to the community when tackling social care. And today we have four great panelists who have graciously given their time to delve into these issues and more. So first we have Ray Faustino, the Chief Impact and Strategy Officer for Aluma. Ms. Ngozi Moses, the Executive Director for Brooklyn Perinatal Network. Jen Lewis Walden, who is the co-founder for Shift Health Accelerator, and Dr. Jason Cunningham, who's the Chief Executive Officer for West County Health Centers. Thank you all for being with us today. So I have to start this conversation with Ray. You are in the social care tech vendor space. An important critique has been that technology solutions focused on social care may have a mismatch in marketing. Often coined as solutions to address social determinants of health, we know that technology alone cannot address the conditions and the places where people live, learn, and work that affect their health and quality of life. The solutions that are getting the most attention in the social determinants of health field are really solutions that aim to connect people to resources to address essential needs. And you wrote a blog post entitled People Over Profit, 4 Lessons from a Panel with For-Profit Competitors, where you began to delve into how you are seeing structural racism enter this space. So I would just like for you to begin with what compelled you to write this blog post and expound on how you are seeing structural racism show up in the space.
Thank you, Arthur. Really appreciate being here. Thanks to you and Health Leads for organizing this whole panel today. So where did I start from writing this panel, writing that blog post? So, as I wrote in the blog post, over the years, we at Illuma have been working alongside for-profit companies. And Illuma is a nonprofit organization, and my organization, One Degree, also a nonprofit organization, merged with Illuma last fall. And as we've been doing this work in this space, working alongside for-profit companies, I started to notice very clear approaches and trends in approach and how the for-profit companies were doing their work. And these approaches became much, much more drastic over the years. And I'm going to characterize them as like very market domination or an arms race kind of approach. And that's kind of like what prompted me to write this blog post, because I knew that there had to be a different way in order to do that, because the way that the for-profit companies have been approaching their work have been really from the playbook of the white dominant lens. But before I dive into that, I really want to anchor our conversation on the American history of colonialism, capitalism, and racism, right? The reason why we've been in this mess is because we're trying to unwind and find solutions to our history of colonialism and capitalism, and our history of building systems of oppression to exploit our communities of color. And the way that we as a community are building and addressing social determinants of health is actually perpetuating these same systems of oppression that continue to exploit our communities of color and immigrant communities and low-income communities. And we can't get to race and class equity without having a healthy critique of the system, which is why I'm so excited about this conversation today, right? And when we think about like how funding and structural racism are entering the work, we can see this very clearly because of the flood of capital that has come into this space, right? When you get an infusion of VC capital, there's perverse incentives that happen, right? So for example, close to $300 million of private equity funding has gone into the for-profit tech companies in the social determinants of health space. That's my estimation after doing a little bit of the back of the napkin. At least one of these companies has a valuation of over $1 billion, right? And you may be thinking, wow, that's really great for our industry. All of this money is being used for to really push the social determinants of health space forward. But unless a specific equity approach is being applied to the work, harm is going to be done. And we have to remember that $300 million in private equity isn't just free money. Venture capital firms expect a return of 25, 35% per year over the lifetime of their investment. And VCs have a lot of latitude and influence on how these companies do business. So in most cases, the only way a VC makes money is when these companies get sold or go through an initial public offering or is acquired by another company. And because of these VC-backed companies are incentivized to scale as quickly as possible so that they can be as appealing as possible for a potential IPO or a potential acquisition. And so they're biased to go after more and more and more and bigger sources of funding and contracts. And generally, they're biased to do this alone as their own company. And it so happens in the healthcare industry, this is one of the most active industries for private equity. And VCs are looking for the next Google, Tesla, or Airbnb in the space. And they're pushing their companies to expand as quickly and rapidly as possible. And it's fine if you're doing rapid scale, if you're selling cars, right, or electric cars. But that rapid scale has unintended consequences for our communities. And as I mentioned, like the VC-backed playbook for rapid scale is written from the white dominant perspective. And that perspective, first and foremost, extracts as much value from communities as possible before regulation comes in. And you can see this from examples like Airbnb, which has perverted the housing markets in cities all across the world. And in the case of the social determinants of health intervention space, you can see that for-profit companies are playing this market domination game before we start to regulate this space, right? It's very, very similar to how companies were playing the market domination game for electronic health records. The same exact situation is happening here. And in this market domination game, what we're seeing is that companies aren't making room for equity in their approach. But in order to truly build these equitable solutions and create health and well-being for our communities, we need to have these companies and have all of our approaches center work on race and class equity and not just profits. So I'm gonna stop there because I feel like I've talked a lot, but that's kind of like where I'm thinking around this.
I really appreciate the background, especially really centering in on this market domination approach. And I know that you're seeing this at a macro lens. Ms. Ngozi Moses, like you're on the ground and you are leading a community-based organization really about the communities, for the community, by the community. And I'm just wondering, how do you see that market domination play out on the ground where you're located? And Ms. Moses, I think you're on mute right now. Let me see.
Thank you for giving me this opportunity to join this conversation. And Ray has just opened my eyes to understand what exactly we've been experiencing that I could not frame in the way that he did, because I didn't know the politics of the business model. But exactly what Ray just described about market domination is something that we're experiencing in New York City with a major technology firm which just promoted, they've just secured $100 million to further expand their technology, which they're offering to CBOs as free, to join them and making CBOs feel unknowingly that they're getting a bargain, which really what they're getting is the higher risk of marginalization and disappearance from the service environment, because now that technology company wants to become the intervention, where we have a community-based interventions. They're seeking to now line these organizations up by offering them free technology and a sign-on bonus of about $7,000 without all the ins and out of it, and saying, we're giving you something free. And I've been trying to tell my colleagues, this is not free, this is marginalization, because then we would not have the capacity to negotiate contracts based on our needs in our communities, because you have this mega agency who's already owned us all on a contract for $7,000 to use the technology free. And I was trying to figure out the business model that led to that. And Ray, thank you. What community-based organization need is not top-down solutions from large companies that come and say, here is what we have for you. I agree with Ray's blog that there needs to be engagement from the community-based organizations to say what will work for them to be able to do their work better, to serve better, to provide better quality care. BPN has been in this arena of trying to collaborate to develop health information technology for community-based coordination, service referrals between and among the CBOs themselves, and partnering with the healthcare system through regional information exchange to communicate the social health service data through the RIO to the point of contact for the medical providers when they visit a client if they participate in a RIO. Now, everybody, we've shown this software tool that we've spent a lot of time and Medicaid money developing, felt it was a bright idea. It was good. It was needed because it gave us control over our data. It helped us to generate the data and the reports that we want to help us manage and grow our business and plan for our community. And it helped the provider and the health system to get data that they could never, ever get any other way. The challenge we had is that although we got some Medicaid money to start that, it was grossly inadequate. It was fragmented. It came in bits and pieces. And when we did work with a local partner who started with nonprofit funding from the United Way and was working with us to develop this technology that we designed, our providers, healthcare providers who we needed to buy into the system, had a major challenge. There are too many technology pieces that they have to connect with to add another technology piece. And that was the death of a technology that was community oriented. We didn't have the funding, we didn't have the audience, we didn't have the table. We did have a small developer, network developer, who worked with about 10 organizations across the state to develop this technology. In some part of the states, it took off, become major systems employed it. In New York City, with its complex health system, this severe and fierce competition for market dominance, and multiple health systems run the health service, the medical providers were reluctant, even though they valued what we were trying to do. And their goals are well-informed, bottom-up, well-informed, intelligent system that never made it after spending about 8 or 9 years doing it, and about $2 to $3 million of Medicaid design money among about 4 or 5 community-based organizations.
Ms. Moses, thanks so much for really taking kind of Ray's framing and giving a real world application to it. I want to continue on with that because you really talked about this notion that a technology can be introduced to a system or to community-based organizations as free, but can contribute to further marginalization, which that's a real experience on the ground. And Jason, Dr. Cunningham, you're in an experience where you're on the ground too. And this is kind of real life as well for you. You sit in a very unique position being a federally qualified health center. And I'm just wondering, are you seeing the same type of marginalization or even risk of structural racism kind of creeping into your space as you're seeing technology being introduced to you and your organization?
Yeah, thanks, Arter. And I just want to echo what Ms. Moses and Ray was talking about. Just this is what we need to be talking about. This is such an interesting, complex, important conversation for us to having. So spending time to have a good dialogue is important. I'm CEO of a community health center. I'm a family doc. I have been in community health for my entire career. Most of the community health centers came out of the Johnson era war on poverty 40 to 50 years ago with a concept that we were participating in and focusing on the most marginalized of our communities. It's our passion. And so now that we have this incredible opportunity with data and information at the social level, at the community level, it's just a huge opportunity. And I think most of us would say we should definitely be thinking about this. This is how we're going to make decisions. I'm scared to death of it. And I can tell you that right now. And just to say that clearly, I am a geeky health data literate CEO. I have a Hadoop node. I have a Tableau and ArcGIS that I use myself in addition to my organization. I connect to large data systems, community-based education and other things. I am really interested in it, and I think there's opportunity. So I don't want to put the concept out there that this is just, we shouldn't move forward in it, but we need to be really careful. And just to kind of give clarity to that, when we have been thinking about the layer of that influence, we need to be careful about who we're influencing, who we're serving, and who has access to participate in that conversation. So when I, as a leader of an organization or as a family physician, am making decisions, I'm making care delivery decisions on behalf of or with a patient that's in front of me. I'm already one step removed from the individual that I'm working with. When we're starting to talk about communities who are serving, particularly those who are marginalized or vulnerable, who have already had historic, and as Ray was talking about, that historic over and over again, being marginalized and having those systems in place to further marginalize them, we need to be really careful. And so the way that I've been thinking about this is, the further we get away from the end user or for the communities that we serve, the more safeguards we need to have, the more humility we need to have in order to make sure that the intervention or the data that we're using is safeguarded from bias and risk. And like what you're talking about, actually creating with good intent systems of bias that overtake it. So a small example for me, I was very interested in the individual social determinants of data, of health data. I want to know, I was interested in looking at my community, understanding the risk factors. And because we come from a systems where we have a scarcity and resources to be able to further focus energy into those areas that would have the best benefit. And I think that's good. We should use data for that purpose. When we start asking patients when they come into my room, what's your adverse childhood experiences? What are the social determinants that affect your health? And they take that survey. They're to a certain extent engaging with me in doing that. I can engage with them on the importance. They're trusting me that I'm going to use that to the best interest of that individual experience. That in itself takes lots of training to make sure that happens well. That's a form that they're filling out, or a digital form that I aggregate myself. The minute we start importing data that's in the world right now, their DMV records, their education attainment, their 600 attributes that you can purchase online. Many health systems do that already. When you're looking at these weighted scores for individual patients or groups, that patient didn't tell me that information. If I know that they were divorced, I know that they had achieved this attainment, I know where they live, that consent was not implicitly given to me in the context of what I'm engaging with. And that inherently, there's an icky factor to say that in a very, I didn't tell you that. How come you know that? Why do you know that about me? What are you going to do with that? How are you going to use that for your care? Even with the engagement that I have with that, I potentially erode the trust that I've so hard to gain. And the trust I take very seriously. So that relational trust that I have with a client of mine or a patient of mine is everything. It allows me to engage around addiction. It allows me to engage around cancer. It allows me to engage around some of these more complex things. The minute I bring in this data, just by bringing it in, I potentially undermine the trust that I've gained from that patient, much less if I'm going to then act on it as a leader of my organization or a health system, or I'm going to say, I'm going to make assumptions. I'm going to assign meanings to those assumptions. And even with good intent, I'm going to put systems in place for information that somebody didn't implicitly give to me, then I'm inherently creating risk. So all that to say, I want to set the tone to say we should engage with this, but we need to be very careful in how we're doing it, not just for that individual, but how we're creating systems to intervene and to support. And then lastly, I would say that when we engage with partnerships, so I'm really quite interested, even in the panels you created here, when we're talking about health systems are getting upstream. We want to get beyond the 20-minute office visit, the intervention. We want to know how to reduce cost. We want to figure out how to work on housing insecurity and addiction or other things. That is way outside of my space, and it should be outside of my space. So we need to engage with communities, engage with community-based organizations. And I think many of us are trying to figure out how to do that. Well, we come with power behind it. We come with money. The health systems do. We come with potential opportunity. That's why, Ray, you were talking about this in huge investment. Most of that investment's because they want to get a hold of that opportunity of reducing costs. That inherently brings about this health system into an environment that we don't normally play in or shouldn't play in. So we need to be really careful about how we're stepping into the space and how we're leveraging that power, either good or bad in the space. So I don't have an answer to it other than to say we need to have a curiosity mindset. We need to be very careful about what we're doing.
Yeah, I really appreciate you bringing up some of the points around the trust that could be eroded in the way that we're approaching collecting data around social needs or essential resource needs. What is also really interesting is a lot of times when we hear about social determinants of health or social care technology, the end user being the client or the patient is sometimes the group that's least uplifted. And actually that data, just hearing you talk, is what's making the technology valuable, because you can take that data that you're collecting, put it with your health system data, and ultimately create assumptions or algorithms, machine-based learning around individuals. And I think what's really interesting, because this is coming up in the chat, when we start talking about risk, we really need to delve into informed consent or build off of that more. But I really appreciate you uplifting kind of the notion that the patient, the client, is the end user, and how are we thinking about them and are we building trust with them in the way that we're approaching this process. I want to bring Jen into the conversation because we're hearing so much about what's influencing this, and of course it's money. And so I would love for you to, really talk about how you may even see structural racism in the way, tech forward solutions are gaining interest or gaining funding. Like, why is this happening in the way that it's happening?
Yeah, thanks, Chair. And I just appreciate this conversation so much and the different perspectives that each of the panelists are bringing. I think one thing that really resonated in the work that we've been doing up to this point and preparing for this conversation is your invitation to sit in problem definition. And I think it's really important, because this is, as everyone else has named, a really complex and nuanced space, and one that's evolving rapidly. So just appreciate the invitation to participate. And I think, where I'm coming from through the work that we're doing at Shift Health Accelerator is specifically launching this effort to shift the narrative and ultimately to shift the resource flow from what predominates in the funding and investment space into a community leadership focus, and to consider the ways that structural racism is actually built into the ways that we work, and challenge ourselves, I think, about new ways of building systems of funding and investment that are prioritizing community voice. The funding systems themselves are actually reinforcing the same inequities that in theory the funding is supposed to be addressing, and resulting in multi-generational disinvestment that's institutionalized and systematized and persistent over time. I think what we're seeing is that the dominant model is that the knowledge and expertise is situated with those that are funding. in the institutions within larger and well-resourced organizations and systems. And so this bias then gets reinforced over time, where resources beget more resources and then focus on a much narrower set of organizations and interventions that have the larger so-called evidence base. Funding then, it flows toward the narrow set of interventions that are able to collect the data, that are able to speak the language of the institutions, but that doesn't necessarily equate with solutions that are working for communities or even improving outcomes. And it locks out all sorts of solutions at a community level. So we need, I think we need to challenge the notions of evidence, of expertise, and of readiness that are currently dominating the funding spaces. You know, we talk about readiness through the lens of capacity, infrastructure, data, and yet we'd actually need to build those capacities if we're going to create more equitable systems. There's a belief that speaking the language is really necessary to addressing people's needs, which I think is interesting because it actually narrows the set of interventions that are funded, because the idea is that if you can frame your work through a health system lens, then that will ultimately be prioritized. But we know that the health system isn't creating health. So there's a problem in that logic. And it locks out the knowledge that rests in people and in places and people who know what well-being means to them and what success would look like. I think the other angle that I want to touch on here is in relation specifically to the tech-forward social determinants of health companies and funding is the time horizon. You know, we're talking about technology that's focused on mostly addressing immediate needs that individuals and families face. Rarely are they now addressing root causes, at least not yet. And even though we talk about it as if it is doing that. That said, it makes sense that the technology and the health systems want to address these immediate needs. They're costly to the system and they're happening outside of healthcare's walls, as Jason just mentioned. You know, and what's driving the investments are short-term high-cost issues like utilization and readmission and cost of chronic care. And data and technology can identify some of the story around what's happening and where it's happening, though that is distinct from solving for root causes. You know, keeping in our field of view the rapid expansion in this space and where the dollars are going. Are they going to companies or are they going to communities that are experiencing this? And really honestly interrogating that question. But I think if we stop there, we're not actually addressing the well-being of places. We have to step back and think about the long-term health of people and in preventing the very immediate needs that these solutions are then addressing. Because if we don't do that, step back into a prevention mindset, then we're never going to actually create health. And it's different than improving on bad outcomes. And that's going to take generational investments. So for us, we've been thinking a lot about the opportunity to hold leaders in communities as the locus of power, really, and recognizing that community leadership is the only way we're going to get to real systems change and real equity and power change. And building the capacity and the infrastructure in this way would be a fundamentally different way of funding. You know, in many ways, I've heard arguments that we need to take these immediate steps first as a pathway to those root causes. And I think that needs to be challenged or questioned as well. I think we're talking about two different value propositions there, and would welcome ideas in that space as well. And just appreciate the opportunity to participate today.
Yeah, thanks so much, Jen. You really unpacked a lot from kind of the risk of us taking this funding approach, particularly how you use this term locking out community knowledge. And it really made me think about the work that Ms. Moses is doing in Brooklyn. And I'm just wondering, kind of looking at Ms. Moses, like, what do you think needs to happen? What needs to change to limit and address harm to the community when we're wanting to tackle social determinants of health or social needs. And specifically for you, Ms. Moses, like when I talk about community, I would be interested in you talking about community members themselves, but also for, groups like yours who, hold so much community knowledge. What do we do to make sure that we are not causing harm to groups like yours? Ms. Moses, I think you're on mute again.
Yeah. BPN is a community-based organization that does everything it does with collaboration. We collaborate with community residents. We pull them into discussion group, focus group. We train them to be voices for health, speaking about health in their community, informing their community members about health issues, participating and training them to participate on some of the forums that are in the community that need to hear their voices, talking to elected officials and things like that. So we partner with our community-based partners to coordinate services and to stay alive. And we partner with the health system to get them informed about what's happening in the community and to share some intelligence about how to best serve the community better. And we partner with our elected officials to advocate for what we think our community needs, trying to them to keep their hands on the pulse. And we do all of this without pay. We do it as a part of our work, just adding on because of the passion that we have. One of the things that is important to engage communities and in processes is to be able to compensate for that time. It is valuable intelligence. It is what private firms pay consultants thousands of dollars to do to collect information. And community-based organizations want to be at those tables to influence discussion and give information, but often we can't afford to be there on our time because somebody else is paying for time for work we need to do at that time. So some of what needs to change is better compensation for community-based organizations, those on the ground in the trenches, among the people seeing them, visiting their homes, the organizations to whom the people come to give them voice because they don't have a voice on their own. Make sure that considering compensation for collaboration and community engagement is done, because often we're stretching thin resources and risking the quality of what we do because we try to do so much with so little, but also risking staff burnout because we're stretching staff in so many ways. We are at a point in time where we're at a once in a lifetime funding opportunity from a government administration that is looking at issues, health and inequities through the lens of systemic and structural inequities and racism. And I have a major fear that this time will pass, this money will go, and that the issues that need to be raised and the people that need to be informed to redirect or make sure that some of that money is directed towards the community-based level, it's not going to happen. I have looked at that act, and with all the good intentions, there is no mention in there about community-based organizations on the ground having structural capacity, the health information technology, the technical experts and things like that. And someone of the panelists, I think the last panelist, Jen, mentioned the need for that investment. Our policymakers need to be in this game. They're putting a lot of money out and they need to make requirements and mandates for who gets that money, what they do with it, and how they engage community. Community engagement needs to be a policy and not just engagement, meaningful, valued engagement where it is measured, because just bringing us to the table, listening to us, and then closing the door behind us after we leave and having that heard or interpreted or interested is what happens a lot. You know, they do the major face forward invitation, but then the engagement is not there. The engagement is lacking to use the intelligence that the community have, and then they pay consultants to come us and ask us what we think through the lens of a third party who may not even be competent, relevant, or even understanding the language that is being shared. And so I feel that elected policymakers, along with the corporate funders who are also pumping money into this thing, those philanthropic organizations that are funding some of this stuff, need to be at the table to understand this dialogue that we're having and to be able to buy into it. The health systems folks, some of them are aware and some of them are not. And some of them are scrambling in this market of dominance to make sure we can stay alive. So, hey, we'll work with the best technology company that give us the biggest breaks without even thinking about what's behind that. So because the profit motive and the competition in this healthcare field is so great that supersedes the reality that we're not going to improve health that way. If we keep doing the same thing the way we've been doing it and invest more in doing it that way, it's just a bigger bunch of madness, because it hasn't really yet given the results that we're spending the money on. In fact, we're seeing worse outcomes. So I think that policymakers and those others that I name, along with we also have to be careful about nonprofits that act like for-profit, because a lot of nonprofits are not community entrenched. They're not community focused. They may have locations and offices and people, but they don't understand the community. So we need nonprofits who are community focused, community in oriented, community entrenched, and who are demonstrating how they value, how they value, how they use community input, because it can all become a nice phrase and a nice game.
I really appreciate the nice phrase, nice game comment that you just said at the end, Ms. Moses, because one, you really picked up on where Jen left off around this lack of community knowledge, but we need to really understand who has that community knowledge, because as you're saying, every organization is not community entrenched. And we also have to examine if we're bringing even community partners to the table from a structural racism lens as well, which is what I hear you're getting at, because some groups are able to come, some groups are not able to come. You also have the issue of people sharing their voice, but it's not actually shaping decisions. So, what does it mean to bring or to have authentic community engagement where the community voice is actually directing the intervention? Those are, getting feedback and having decision-making power are two different things. And I really appreciate you uplifting that. I saw a question in the chat around social determinants of health data. And that's the concept that I think Dr. Cunningham brought up. And I wanted you to speak more about that, and also really talking about what we need to really do, or what you think we need to reflect on as we are collecting this type of data that I hope you expound on, and the way we're using that data, particularly when we're starting talking about artificial intelligence and machine learning tools that could really cause harm when we're looking at the interpretation of that data.
Yeah, thanks. I just really resonating with Ms. Moses, what you're talking about, Jen, kind of thinking about that capacity building. If we're talking about intervening, supporting, investing in communities to change the narrative, that capacity building is we need a lot of work on that. I spent a year in Denmark at the University of Copenhagen looking at longitudinal data sets that they have for 40, 50 years. They're also scared to death of this because they've got a trust built in their system. 70% of the Danes think their health systems, think their government is doing a good job. We have like 20%, and they've got this incredible amount of data. They're worried they're going to lose that trust. There was a group out of Sweden called MyData, M-I-D-A-T-A, that was using blockchain. I saw that in there to have the actual end user own their data set, and that whatever intervention was being taken from that, the end user would get value from it. I think those are some of the discussions we need to start thinking about. But what I really want to talk about, which is what Ms. Moses was talking about, it's messy. When we're talking about intervening on social determinants upstream, it's hyper local. It's part of the community. That concept of bringing in the social determinants of health data as kind of, here's the answer. You don't have to go to that messiness anymore. It's right there. In fact, I'm gonna put the algorithms behind it to weight it. You might not see it, but you should trust it. You don't have to go and actually do the deep systems mapping and the community engagement and the co-design and what does it look like to develop the engagement around, I think this is interesting, I'm curious about it, I need to go and look further. I need to really not just ask and have, hey, do you think CBO, this is a good idea, but I'm really curious about that. And I need you to help co-design the outcomes from it. That's messy, it's not efficient. It doesn't lead to return on investment at the 25%. That's deep in the weeds of community engagement. And I think we have to step back to say, isn't that what we're trying to do, is actually intervene in a way that's going to bring about better investment in the community? And we have to step back to say, it's systems mapping, it's community engagement, it's active listening, it's curiosity, it's a design mindset, all those things that we're talking about. Data can inform that, but it better not be the driver. And we better not be naive to say all this big social determinants have had data then negates that need to do that, which is what I'm really curious about. Now I know more because I have that data. I don't need to go out into my community anymore to ask that because it's now right in front of me, and it decreases that need to kind of get in that space. So I'll end it there just to say there's a lot more that we need to engage with and be slower in what we're doing in order to really gain real action.
And what I'm hearing is engagement at the beginning process, and then also when it comes to that data interpretation, that there has to be engagement there for some type of verification that, hey, this is, for the biases to be checked, for, for structural racism, all those different things that could creep up into the interpretation of the data. If the community is not part of that process, then you still run that risk. And I think you were talking about having that engagement all the way through, especially at the co-design building process, but also at that ending when you're seeing the data come out. Is it perpetuating bias and creating harm? Yeah. Jen, I want to bring you in, especially as you are in a situation of, you sit in between what I say is community-based organizations or community entrenched organizations and funders. And, what role can, community-based organizations have in influencing the investment? What can they be asking funders for? What could they be asking health systems for? Have you seen that show up in practice as you worked with community-based organizations?
Yeah, absolutely. I mean, I think what this conversation has been touching on in terms of being involved in the design of technology solutions from the outset, but then over the course of the entire process, I think is critical. I mean, if we don't build in equitable processes, we're never going to get to equitable outcomes. So I think, what we're talking about in terms of centering the needs of the organizations that are using the technology, as well as those communities that have had historical disinvestment, I think is absolutely central. And it's a different way of doing business. I want to go back a little bit to the data question too, because I think that the ways we are thinking about the design of these systems and whose voice is reflected in those systems or not reflected in the systems is really important. And thinking about not collecting more data, I think as was mentioned earlier, but how do we use those dollars to invest in community leadership and capacity building and the infrastructure that Ms. Moses was noting, the ownership of data in communities to then make decisions with additional resources behind that. So I think what we're trying to do is actually shift the locus of where the funding is going into hands of communities in order to make decisions around that funding. And the technology piece is really interesting because, I think what we're seeing is that the technology as it's currently being operated somewhat in silos, it's requiring continued investments of dollars to keep up with the technology itself. I was involved in a project a couple of years ago where a large technology company was hired to create a no wrong door solution. So the initial design was created, and then the project wanted to test the technology with a particular population or set of needs. So that required more funding. Then there was a gap in integration and in capacity to use those new tools, and there was a want to test it again with a different population, different set of needs. The point is that the technology company was driving the decision making around the design of the technology, certainly, but also the need for funding to continually chase the solution. It was sole sourced, and to add on components to the project, it was never transferred in any way to community. And so I think the design was flawed from the outset for sure, but I think also raises the point about the continuation of investment into finding solutions that, in a sense, can be somewhat never ending. And the other point, going back, Arter, to the question you mentioned around bias in the algorithms themselves, I think that's also something that's super critical to keep top of mind in this space, because even if at best a technology company or solution is thinking about reducing bias in their algorithms, let's say, the ways that technology is then integrated into other systems doesn't preclude from the bias from other systems generating bias in the ultimate data picture that is created. And I think, a lot of in this space, we're talking about interoperability of different systems. And so we would need to take that out to a much broader level, I think, in terms of thinking about the bias that's inherent in some of the legacy systems, as well as the new technology systems as well, because then the idea is that they're all connected at some point. So I think that's also really important to consider.
Yeah, I love that you really talked about the technology at the end, the technology that's around social care can have bias, but it's also being connected to other systems, other tech systems that have bias as well. And that we have to be mindful of that. Ray, you really started off this conversation by really laying out this framework that everyone could really relate to and could expound upon around, why the market has moved in the way that it's moved. What are some of the risks that are associated with that? What are some of the harm that's already occurring with that? And I just want to ask a broad question of what types of activities are required for platforms to be developed in an equitable, inclusive way? What do you think needs to happen there? And I want to tie in another piece, because a lot of people are talking about the metrics of success. So what are the metrics we should be looking at to give us some type of indication that we're moving more in an equitable way, that we're not perpetuating health disparities?
Great, really, really great questions there. And so I want to start this by thinking about the framework a little bit more deeply. So at our organization, Aluma, we're having a pretty regular conversation about how to decolonize our work, because we know that the way that we do work in the United States is we inherited white dominant structures, right? Even the very thinking about corporate structures and hierarchies was created to control people and to squeeze and extract value from people, right? And to get work done, right? And so we know that we're swimming in kind of this sea of white dominant culture, and we're trying to parse out what exactly it looks like in our organization. And we also know that the approach with which we do our work shows up in the impacts and the outcomes that we want to achieve for our communities. And so there are a couple of themes that I'm seeing. So like the first theme is like this is power hoarding versus like power sharing. And then there's like this competition versus collaboration, right? And there's a major issue right now in our space around power hoarding and competition, especially because of how the startup and technology world and culture tends to drive companies to consolidate power into the hands of a very few, usually white, usually cisgendered male people, right? And you can see this across the board in many multiple industries. And you can also see that in this power hoarding mentality, a lot of ideas and concepts from our communities are treated as throwaways or a threat or information that's not really that useful for folks. And there's a lot of like scarcity mindset and zero-sum game thinking in this world of like power hoarding and competition. Versus on the flip side, if you think about like sharing power, which is also very, very difficult, but something very necessary for what we want to do and make an impact. Solutions can come from many multiple levels throughout the community, all the way up through the system, and are valued and implemented for the proximate expertise that they're representing. And ideas and concepts are requested, and you can make space for those ideas to be heard, and resources, more importantly, resources are shared equitably and appropriately in this space. And what I want to say is that power hoarding and competition aren't necessarily just issues with the for-profit tech companies, as Ms. Moses mentioned earlier. Even nonprofit organizations fall into this trap, right? There's multiple times that we've been into situations with white dominant power hoarding perpetuated in traditional nonprofit organizations that are incumbent in this space, like United Ways and 211s. I remember when I was first starting One Degree over 10 years ago, I approached our local United Way 211 about the concept of One Degree and how we could work together to make this happen and empower our community and bring in community voice to do this. And I was largely ignored back then, probably because I'm a person of color. I wasn't connected to their networks. I didn't have funding to go with my conversation. And that just continued the status quo for what they were running, right? And years later, where are we at with the traditional incumbent systems of 211s in this space, right? Are 211s collaborating? Are 211s open? Are they innovating in this space? Some are in pockets throughout the country, like in San Diego, which is fantastic. But by and large, power hoarding is the issue that's happening in this space, and that needs to be majorly addressed as the next step in this space to really get to where we need to go. The other thing I'll say about this is, you asked about like activities required from these platforms to develop this equitable inclusivity. We have to ask very simple, basic questions in this space of these for-profit companies. Who is on your board of directors? Do you have community representation? Are there people of color on your board of directors? Who's on your executive team? Are they all white? Are they all male? Are there community representatives? Are there people of color on your executive team? Who's on your staff? Same question, right? Does the staff, does the board, does the executive team have proximity to the communities? Or are they operating from a tower in New York City when they're supposed to be working and scaling in rural Georgia? You know what I mean? Where is the proximity here? So once we start asking these base level questions, then you can get deeper and ask like, okay, well, what kinds of community input is happening? And then what kinds of direct community, not just engagement, but like involvement in this space? Like, how is the community in the organization and running the organization? And how are they included in making the decisions? Those are the very basic things that need to happen even before we can get to the next stage. And there's so many more things that we need to do once we start like just from that square one, but we're not even there yet. A majority of these companies are all white led, generally male, and they don't care. Like, there's no accountability for that, right? And they're supposed to be working in systems that are disproportionately affecting Black and brown communities, and they're making millions of dollars and exploiting our communities and making millions of dollars. How are we all still calm about this, right? Like, how are we all like just relaxed and like going about our business when people are literally extracting and exploiting from our communities? That is, I'm getting heated, so I need to calm
No,
down
I
a little
really,
bit, but
That's great. That's great.
yeah, I really appreciate it. Go ahead, Ms. Moses.
Yeah, I would like to build on what was just shared by Jason and Ray, because we have a live example happening right now in New York City in line with that. We have a major technology company, the one I said that just advertised to all of us in the world, we've got $100 million, new money, venture capital money, just secured $100 million. And a large nonprofit that is known to be a major manager of our city health department contracts, probably has about 60% of the contracts or more, have teamed up. And the only engagement they've had with anyone in the community is seeking to have conversations to just help them know what they want to know, to strategize, how they want to strategize, not conversations of engagement. Now, BPN and some community collaborators who work together on the DISRIP health reform, and we got together particularly as a group for DISRIP, was part of a citywide process to select what you will call an entity that can come together as a citywide coordinator for a phase 2 district money we're expecting to get with this new administration. COVID happened and that collaboration went to sleep, and one of the major organizations decided it will fill the gap and move on alone, using the intelligence of that collaborative process, but then coordinating what this major technology company to provide a solution that they think will work. And BPN and our collaborating partners from that community process, which was engaged in a major process, we took the risk of reaching out to that white, very rich, very male, very non-community community to say, hold a minute. What's happening? How did you fill this vacuum? And why aren't we in the conversation anymore? And the response was, oh, we didn't even realize we were doing that. It was like a total lack of acknowledgement that there was another way, or there should be another way of doing that. And the response appeared so genuine coming from who it came from. I'm wondering whether there really was a mental block all the time while this collaborative process supposedly was going on. Because here it is, this same company, this same partnership, acting more like a for-profit partnership, actually has the capacity, if it took a more collaborative approach, to do good by engaging the voices, because it's already positioned, the major nonprofit is already positioned within the government structure to work with a lot of community-based organizations. But is it open? Is it truly open? Or is it just words that are being said? Is it truly open to understanding what community engagement and involvement mean in these times? And we're at the table with them talking. They're probably on this conference, and I hope that they are, and that they can probably figure out, oh, Ngosi's talking about us. I really don't, I'm not worried about that, because I talk all the time about these things, and it's part of who I am. We take the risk of raising the issues that other people may not be aware of, or they may not want to talk about because they're afraid of the hand that feed them, biting the hand that feed them kind of syndrome, and then they get locked up. And that's probably happened to us a couple of times, but it doesn't stop me, at least, from talking. But the thing is that we have asked some of those questions and asked them to look at some of those questions. This major technology company, who has it engaged with on the community level to know what the community wants to be able to offer in a solution? And when outreach is made to that community to do some of what we think need to be done, the answer is we are not interested in going in that direction. Clear answer. We are not yet. It is a prominent partner. And likely the intention is to leverage this tsunami of government funds that will be flowing, because now we are positioned with 60% of the community-based organizations contract in the partner that we're working with from the Department of Health. So I feel that this conversation that Health Leads is having with almost 1,000 participants is what needs to happen more and more, because we can't wait for the solutions to come down. We have to push up from the bottom, and we have to raise our voices, and we have to keep knocking on doors, and we have to have opening this dialogue and just let the air out and let folks know we're serious, we care. You may as well start listening, because there's a chance that some of what we're doing could bubble up to impede. Until Black Lives Matter happened, a lot of people deliberately had blinders on. Some didn't know they have blinders on, and some was just in left field. And so there's no excuse now to not know. There's no excuse now to not listen and pay attention. And those who are still moving in that direction need to be called on the carpet, And these need to be public discussions, not boardroom discussions, because, it could start in the boardroom for them, but it needs to come out into the community for us. Because we are the community-facing organizations, and they look to us for protections. When they give us their consent for something, they're trusted that you really know, our fears, our distress, and how we expect you to behave. And so we have refused to join some of these initiatives, and we have come up with proposing alternative initiatives. We're currently working on a system called the Community Pathways Hub that require us to control our own data, and finding the data system that will work for us, there is no interest, because they want to control the data.
Mm-hmm. I just want to, I have to step out of the moderator, hat for a moment, just to thank you, Ms. Moses, and you, Ray, for bringing into the conversation around race, and the fact that what we're seeing is, if you're white leadership, there's a higher likelihood of you getting funding, you being able to have control. And that's something that oftentimes, some hesitancy in bringing that up. And I also want to just state that it's often people of color who have to labor and toil in bringing this up again and again and again and again. And it's really important for people of color and other marginalized groups or other groups who are experiencing oppression to not be the only ones. Because as Ms. Moses, you were bringing out, if you were not aware of structural racism before the Black Lives Matter movement, you're aware of it now. And so it's important to lean in. It's important to understand what it takes to dismantle systems of oppression, because you just can't look at something and just say, oh, well, it doesn't affect me. It doesn't it benefits me, and just walk away from it, because you're now contributing to the problem. You're now complicit. And so it's really important, as Ms. Moses was bringing out, and Ray, that you were bringing out, that we have to have these questions asked, and they need to be done in public, because it's really important for us to not position ourselves in a symbolic gesture manner, that we're not just symbolically talking about equity and not doing anything about it. So I just want to thank you all for leaning into that piece. I also want to thank Jen and Dr. Cunningham. I call you Jason all the time. So Jason, thank you so much for leaning into this conversation, and some things that we just really need to be thinking about. When I think about what Dr. Cunningham brought up, when he started talking about eroding trust, if our clients or patients knew our approach to how we're addressing social needs, would it yield more trust or less trust? Are we putting CBOs in a position, as Ms. Moses mentioned, to be more marginalized? Are we locking out community knowledge? That was something that Jen, you brought up. And Ray, you brought up so many things for me to reflect on, but I think, really reflecting, are we using a white dominant lens when it comes to addressing social needs, looking to address social determinants of health? Is something that we really need to think about. So that calls us to think of who we're bringing into the conversation. There's so much that we can reflect on. This recording is going to be available. I know that got brought up a lot of times, and we're going to try to have notes the best way we can, and we're going to make sure we're pushing out resources that were mentioned in the chat and over this conversation. But I just really want to thank our panelists for just engaging in this conversation, and thank you all for attending. We look forward to connecting with you again soon.
Chair, if there is 1 minute, I'd just like to mention
go ahead.
Cybersecurity.
Yes, go ahead.
Yeah, because it's a capacity issue that Jen and Jason and the others talked about. There's been all this attention paid to cybersecurity and the risk and the breaches and things like that. And true to the lack of capacity in communities and the inequities and the disparities, community-based organizations are not only not engaged in the thinking and the looking at where risks lie in terms of capacity and weak points in the chain, and neither do they have the money to even get into the conversation of expert capacity to address that without additional funding yet. And community-based organizations being partners and participating with these large data systems, they create the perfect opportunity, backdoor opportunity for cyber attacks to happen, because they will remain the weakest links. And it's something I would really like to get attention on a larger scale, because the health information capacity is not there. The health information resources is not there. But whatever capacity we have and whatever links we're being linked up to, it is linking it could create a link that exposes larger data systems with a lot of our community information to cybersecurity attacks. So I just want to add that in maybe as your next conference topic.
Thank you so much. And I do think it's really important for us to think about how we're protecting information from community-based organizations and community members. We often talk about it on the health system side, but we also have to talk about it on the community-based organization side as well. So great points. Really appreciate everyone. Thank you so much for participating, and thank you everyone for joining. Hope you have a great rest of your day.